Hi guys, this is Dr. Natisha Arora. I am a consultant radiologist based from India. I have recently passed multiple examinations which include the NEET PG, the USMLE steps 1 and 2, and I have also completed my FRCR and European Diploma in Radiology. Giving so many exams, I feel that there are some topics which are common to all these examinations and which are very commonly tested. So here I am trying to make these topics little bit more simplified in the form of MCQs. I am going to cover the entire topic from A to Z. So let's start with sarcoidosis, which I feel is very important, and it is going to come in any of your examinations in some or the other way. So let's start with our first MCQ. So the first MCQ is, a 32-year-old woman presents with dry cough and fatigue. Chest X-ray is given. Which is the most likely diagnosis? Okay, so obviously we are discussing about sarcoidosis. The answer is sarcoidosis in this case. But what I am trying to emphasize is that they are going to test your chest X-ray interpretation of sarcoidosis. What is it? It is lymphadenopathy. What is the most common pattern of lymphadenopathy which presents in sarcoidosis and which is going to be tested? It is bilateral hilar lymphadenopathy and right paratracheal lymphadenopathy. So I am talking about this mediastinal lymph node enlargement which is commonly tested on the chest X-ray, and here you can see that there is the enlarged bilateral hila. Okay, I'm not able to show over here the right paratracheal lymph nodes, but what is the characteristic pattern what they test is bilateral hilar lymphadenopathy and right paratracheal lymphadenopathy. Mind this is also called as the 1, 2, 3 sign. Okay, the 1, 2, 3 sign. Why is it called as 1, 2, 3? 1 is for the right hilar lymph node, 2 is for the left hilar lymph node, and 3 is for the right paratracheal lymph node. Okay, so that is the 1, 2, 3 sign that is commonly tested on chest X-ray. Okay, the another important thing over here is that what is this sign also called as? This is also called as your Garland sign. Garland sign. Now why it is called as Garland sign? It is not resembling a garland. Okay, so many students, they basically confuse that it looks like a garland. It doesn't look like a garland. It was discovered by a radiologist named Henry Garland. This sign, the 1, 2, 3 sign or the lymphadenopathy sign, this was discovered by Henry Garland. So that is why it is called as the Garland sign. Okay, it is called as your Garland sign. Okay, the another important thing is that this is also called as your pawnbroker sign. Pawnbroker sign. Okay, so you can see that in this one MCQ I have covered so many signs: Garland sign, the 1, 2, 3 sign, the pawnbroker sign. So what is this pawnbroker sign? So I am going to show you an image. This is your pawnbroker sign. Okay, this is actually the pawnbroker sign. You can see that there are these 3 balls. Okay, so what they are trying to say is that this lymph nodes, they also look like these sign from the pawnbroker. So this pawnbroker is basically a sign that is in front of the door of these pawnbrokers. Basically they are loan lenders, and it is mainly coming from the UK, from the British system. So this is called as a pawnbroker sign. Okay, weird comparison, but it is there, it is known. It is called as a pawnbroker sign. Another important pawnbroker sign. Okay, another important thing is that this is also called as the potato nodes. Potato nodes. Okay, so this is also called as a potato node. So this is all about the lymph nodes which are seen in sarcoidosis. They are not only limited to mediastinum. Sarcoidosis mein lymph nodes can be present head to toe in the entire body. On any of the lymph nodal system can be involved, but most characteristically tested is your chest X-ray. Okay, moving towards quick epidemiology. Okay, so this is mainly seen in middle age group. I would say somewhere between 20 to 40 years of age group. Male is to female ratio. What is the male is to female ratio? It is 1 is to 3. Okay, so more commonly they will give you a female patient. Okay, more commonly they present in middle age group, female patient. Okay, race, it is actually commonly seen in the African Americans. Okay, so if you are basically giving any global examination, they commonly give you a ethnicity also. They give that there was an African American man. Okay, this is more commonly seen in the black Americans. It is like almost 3 times more as compared to the whites, and this is commonly basically given in the clinical vignette questions, especially if you are giving any global examination. And what about the histopathology? I am sure everyone knows it. It is non-caseating granulomas. non-caseating granulomas. Very commonly they test this either in the clinical vignette. They will give that the histopathology report revealed non-caseating granuloma, or one of the answer stems will basically give you that these are the non-caseating granulomas which are commonly seen in the sarcoidosis. Okay, so next we are going to talk about the staging. Okay, so what is the second question? Scadding staging in sarcoidosis is based on. Okay, so this is basically based on your chest x-ray. So what x-ray which we have seen before, it can actually be used to stage the sarcoidosis. Okay, so this is again very easy question, but it is very commonly tested. So basically they can even give you a chest x-ray and they can basically ask you to tell us that what stage of the sarcoidosis or what stage of the disease is being shown in this image. Okay, if they want to give a little bit higher difficulty level, they will not even give you the diagnosis. They will just give you the chest x-ray. In that case, you have to diagnose that this is sarcoidosis, and from that chest x-ray you also have to make the staging. So the first x-ray which I had given, okay, again I am putting a third question over here, which is the same x-ray. A 32-year-old woman presents with dry cough and fatigue. Chest x-ray is given, which is the stage of the disease shown in this image. Okay, so you can see that again the same image, we have got lymph nodes, but can you see anything in the parenchyma? Parenchyma is absolutely smooth, it's absolutely clear, right? So there is no parenchymal disease, and this is not a normal x-ray also. You can see definitely there is some hilar enlargement, there is some lymphadenopathy which is present. So basically when we talk about the staging, whenever the lymph nodes are only present and there is no parenchymal disease, that becomes your stage 1. That becomes your stage 1. So the answer over here is, this is your stage 1 disease. Okay, so this is the stage 1 of sarcoidosis. Stage 0 is absolutely normal chest x-ray. Stage 2 will be parenchymal disease plus the lymphadenopathy. So basically whenever the lymph nodes are present, I would say it is relatively earlier stage, or it has basically got a better prognosis. Whereas stage 3 is only parenchymal disease. Only parenchymal disease, and actually it has got a little poorer prognosis as compared to the stage 2, because stage 2 में lymph nodes है मतलब कि there is relatively better prognosis as compared to stage 3, right? And stage 4 will be your last stage, which is basically fibrosis. So remember that the stage 4 fibrosis, not all patients go into fibrosis. Only 5% of the patients will go into fibrosis. Okay, so I have written and included this percentages. This is what percentage of people present with these stages. Okay, so normal chest x-ray जो लेके आएंगे, that is only 5 to 10%. Hilar and mediastinal lymphadenopathy is around 50%. Whereas stage number 2, which is lymphadenopathy plus the parenchymal disease, that is 25 to 30%. And diffuse parenchymal disease, again it is not that common, it is 10 to 12% only. Why I have included this slide and why basically this is an important slide, because they test you that what is the most common presentation. Okay, so as I have told you in the first MCQ also, the most common presentation is hilar and mediastinal lymphadenopathy, which is 50% of the people will be presenting. So this is the most common presentation. The most common presentation is stage 1 sarcoidosis. Okay, so this is an important point you should know, that stage 1 sarcoidosis is actually the most common presentation. Okay, whereas pulmonary fibrosis, that is very rare, very less people actually progress to the last stage, which is fibrosis. Okay, moving towards another important thing is that this is not only called as scadding, it is also called as a Silsbach classification based upon the scientists who have discovered the staging on the chest x-ray. So this is called as the Silsbach classification. So either it is called as Silsbach or either it is called as scadding. I am telling you both the names because they can confuse you, but actually it is one and the same. The classification, the staging, it is absolutely the same. And also remember that there is stage 0, which is normal chest radiograph, and there are people who present with sarcoidosis with a completely normal chest radiograph. Okay, that will not rule out sarcoidosis. So if there is a high clinical suspicion, we have to go for other testing, which we will subsequently cover in the further slides. Okay, next important thing is, which of the following laboratory abnormalities is commonly seen in sarcoidosis? Okay, so here we need to know that what are the clinical and the laboratory abnormalities. So what are the lab findings? You will see that the ACE levels, which is the angiotensin converting enzyme levels, it is going to increase in sarcoidosis, right? So this is very, very important, and again it is very, in some or the other way they will give you in the clinical vignette that the angiotensin converting enzymes are elevated. Or what is the next step in the management? What will you do? You will go for a laboratory diagnosis of ACE if the normal chest x-ray is there, but you have a very high clinical suspicion for sarcoidosis, and another differentials like say tuberculosis or berylliosis, all these differentials have been excluded. So you have to go for ACE levels. Another thing is that there is an increased activity of 1-alpha hydroxylase. Because there is an increased activity of 1-alpha hydroxylase, what happens is the vitamin D levels increase, there is going to be hypercalcemia. Okay, so there is going to be increased calcium levels, and this is what they have tested over here. Which of the following laboratory abnormalities are seen in sarcoidosis? It is hypercalcemia, because there is increased activity of 1-alpha hydroxylase. 1-alpha hydroxylase basically kahan se secrete hoga? All these things, ACE levels, 1-alpha hydroxylase, these are those non-caseating granulomas which are present. They are going to secrete these particular pathological markers, which is ACE levels, the 1-alpha hydroxylase, and 1-alpha hydroxylase is going to increase your calcium levels. So, jo granulomas hai, they are actually the main pathology behind all these particular laboratory findings. Another important thing which basically tested in NEET PG is, which test is used? It's the QUEEM test. Okay, so what happens in this particular test, this is absolutely obsolete, we do not use it right now, but what happens is you're going to give 0.1 ml of normal saline that is mixed with some sort of human sarcoid, maybe from spleen or maybe from the lymph node, and you will see some reaction if the patient is positive. So this will actually give you a very good sensitivity. It is 70% sensitive. It is 70% sensitive, but the specificity is not that great, and that is why we are not using this. Okay, so this is the QUEEM test which we are basically testing for sarcoidosis. It's very, very sensitive. People who have sarcoidosis, they will present with this. The true positive rate is very good, but it's not very specific. Okay, it's not very specific for sarcoidosis. So that is all about our QUEEM test. Okay, so let's move towards our next question. Which of the following radiological signs is depicted in the image? Okay, so before I see the options, let's move towards the image. So what is this image? This is an HRCT image. This is an HRCT chest axial image that has been taken, and you can see that there are the vessels being over here. These are your pulmonary arteries, and these are your lung parenchyma. So you have seen that in the parenchyma there is some nodule. There is some nodule is present. Apart from this, you can see some small nodules over here which are present in the periphery. Okay, so it's basically like this, a nodule that is being surrounded by some small nodules. So what is this representing? This looks like a galaxy of stars. Okay, so the question and the answer over here is galaxy sign. Okay, if you do not know this sign, just look at the other options also. Maybe by ruling out the options, you can reach towards the next, towards your most correct question. Okay, so first is tree in bud sign, which is very characteristic for tuberculosis. You will see some mucus plugging, and you will see very characteristic centrilobular and reticulonodular opacities, which is a tree in bud sign, which is especially seen in miliary or endobronchial spread of tuberculosis. Whereas reverse halo sign is also an important question. We will cover in our subsequent video series, which is atoll sign. So what happens is that there is a central ground glass opacity, okay, which is going to be surrounded by consolidation. Okay, which is going to be surrounded by consolidation. So that is your atoll sign. This is very, very characteristically we see in the patients of atypical pneumonitis. Okay, and another atypical pneumonitis is basically some viral, like for an example, it was even seen a lot in COVID cases. I have seen many cases of reverse halo sign in COVID positive patients. So that is reverse halo sign, and very classically it is also tested for cryptogenic organizing pneumonias. Okay, so for cryptogenic, when we will discuss about interstitial lung diseases, we will discuss that reverse halo sign is very characteristically seen with the COP sign. The another thing is crazy paving pattern. So when we talk about crazy paving sign, it is basically ground glass opacity with smooth interstitial septal thickening. It's very diffuse usually, and it is commonly seen with the PCP, with your pneumocystis carinii, or it is seen either with your pulmonary alveolar proteinosis. Okay, so it is very, very diffuse. It was also seen in COVID-19, but here we are talking about just a nodule surrounded by some nodules. So this is your galaxy sign. Again, an important question for your NEET PG. Okay. Moving towards our next question. a 35-year-old woman presents with fatigue and bilateral hilar lymphadenopathy on chest x-ray. So now you can see that what they are testing is again a middle-aged woman hai. They are presenting with hilar lymphadenopathy. So when it comes to hilar lymphadenopathy, again our mind will go that yes, it can be a case of sarcoidosis. Okay, another thing is that now they have given a confirmation that yes, serum ACE levels are also elevated. So we now reach to a diagnosis of sarcoidosis, because bilateral hilar lymphadenopathy can be present with cancer, can be present with tuberculosis, but if they have given serum ACE levels, they are basically talking to you about sarcoidosis only. So what is the most likely HRCT finding over here? So one thing which we have already covered is that you will see galaxy sign. I'm basically listing some HRCT findings. So one is your galaxy sign. Okay, that is basically a central large nodule surrounded by small nodules. That central large nodule was actually formed because of the coalescing of this multiple small nodules. So now you need to remember जो ये nodules आते हैं, where in sarcoidosis these nodules are basically seen, or where are these granulomas, this non-caseating epithelioid granulomas located in the lung parenchyma. And I am going to list the most important distribution, which is perilymphatic. This is the key word, perilymphatic distribution. Okay, so where is this perilymphatic distribution in the HRCT in the chest? This is going to be seen along the fissures, perifissural. Okay, so basically these are all the locations which are perilymphatic. So one is perifissural. You can see this, 1 minute. So it is perifissural. One thing is perifissural, which is along the fissures. You know the fissures in the HRCT chest, that is basically your along the major fissures. So one thing is perifissural. The second thing is subpleural. Just a minute, I'm going to set this for you. Okay, second thing is that it can be subpleural. The third thing, which is basically your peribronchovascular. Okay, जहाँ भी vessels हैं, hilum है, उसके आसपास you will basically see these small nodules. Okay, so if you see the first option, centrilobular nodules with tree bud pattern, we have seen that this is characteristically seen with TB. Okay, what about C, random nodules which are scattered in the lung parenchyma? No, this is more of sort of random nodules are more commonly seen with say hypersensitivity, pneumonitis, or it can be also seen in tuberculosis, or it can be seen in some sort of metastasis. It is not in sarcoidosis. You don't get random nodules. Okay, whereas question number D, consolidation with air bronchogram. So yes, consolidation can be seen in sarcoidosis when we talk about alveolar variant of sarcoidosis, but most commonly your sarcoidosis is perilymphatic nodules along the bronchovascular bundles and along the fissures. Okay, so this is perilymphatic. We have already seen along the fissures, bronchovascular, subpleural. This is the mantra for sarcoidosis. You need to remember perilymphatic. Once you know perilymphatic, where are these limbs? This is perifissural, subpleural and peribronchovascular. Okay, so that is basically about your sarcoidosis distribution. This is a very nice important slide. I have taken it from the European Congress site, and you can see that the causes of the perilymphatic nodules, this is not only limited to sarcoidosis. This is also seen with lymphangitic spread of carcinoma, which is basically your lymphangitis carcinomatosis. Okay, and it is also seen with pneumoconiosis, but again the history will be little bit different, because in pneumoconiosis you will basically get some sort of occupational history, whereas in lymphangitic spread you will get a history of either breast carcinoma or a lung carcinoma, and it's more of focal. Sarcoidosis may usually it is seen in youth. It is asymptomatic. It is usually bilateral, and there is no pleural effusion. Okay, so that is basically about your perilymphatic distribution of sarcoidosis. If you see this image, you can see this is यहाँ पे pleura होगा, right? This is the pleura, the most periphery part of the lung. So this is the pleura. So there is subpleural distribution of the nodules. Another thing is this, you can see this thin line over here. This is your fissure. So this is perifissural. Okay, this is perifissural. What is this? This is peribronchovascular. You can see that there are the vessels over here. So this is peribronchovascular. Okay, so here this is a very important representation, that you can see that these are all your distribution of your nodules in the sarcoidosis, which is basically perilymphatic spread. Here this blue. Okay, let's move towards our next slide. This is again, I have covered some HRCT images, so they can also give you not simple galaxy sign, and they can show you these nodules. So now I think you have got a better idea along the fissures, okay, along the vessels, some nodules you can see along the vessels also, that is along the peribronchovascular pattern, and this is basically your subpleural distribution of the nodules. So that is basically about your perilymphatic spread or sarcoidosis, which is commonly seen. This particular X-ray, if you this particular HRCT image, if you see, you can see that there is a diffuse ground glassing. So this is something which is atypical sarcoidosis. Okay, so this is little higher edge. They usually will not test you on NEET PG, but if you are giving some higher level examinations, they can test you for this atypical sarcoidosis. You can see that here the entire lung parenchymal space is involved. So this is basically a case of alveolar sarcoidosis. Okay, this is a case of alveolar sarcoidosis. Okay, let's move towards our next question, which is PET-CT in sarcoidosis is most useful for. Okay, so it is used in diagnosing liver cirrhosis, it is used in detecting malignancy, assessing active inflammatory lesions, or localizing the gallstones. Okay, so it is a very easy and very logical question, a common sense question. The answer over here is to assess the active inflammatory lesions. We need to know whether it is an active sarcoidosis or whether it is chronic sarcoidosis, whether it is an old case. So for activity, more active the lesions will be, more hot it will be seen on the PET-CT. Okay, more will be the glucose FDG avidity will be more in those granulomas which where there is an active sarcoidosis lesion. So it is mainly used to see the active inflammatory lesions. So with this, you need to know that actually sarcoidosis can also present in an acute form. Okay, so what I have given over here is that there is again the same X-ray, the favorite X-ray of sarcoidosis, which is basically your bilateral hilar lymphadenopathy. Another thing over here is that this is basically a foot image, this is a lower leg image, and this is basically the shin part, the interior part of your leg, and you can see that there is a lesion over here, a red inflamed lesion. You can see it's looking relatively like, I would say little bit like cellulitis, but it's not cellulitis. So the patient was presenting with some tender nodular lesion. So this is basically your erythema nodosum. Okay, the history characteristically over here is that these are tender nodules. Okay, these are tender nodules which are present on the interior aspect of the leg. Okay, so that is one thing. So one is हमने देखा bilateral hilar lymphadenopathy, second is we see erythema nodosum. The third thing over here, you can see that this is ankle region, and this is the wrist region, and these are very red. They are looking inflamed. Okay, so this is basically your arthralgias. Okay, so this is arthralgia, which is bilaterally symmetrical. Characteristically, when we talk about this particular syndrome which I am going to discuss, this is basically in the ankle region, very characteristically seen in the ankle region. So what triad I am talking over here about is bilateral hilar lymphadenopathy, erythema nodosum, and third is bilateral symmetrical arthralgia. More commonly they will test you for the ankle region. Okay, and this is basically seen with Lofgren syndrome. Okay, so this is an acute presentation of sarcoidosis. The patient may also have fever. They will have this triad, and when we talk about acutely, so patient will be actually in pain. In this case, you have to basically treat the patient with either steroids, or you have to give, if it's very aggressive, you might also have to consider some immunosuppressants, which is basically either methotrexate or cyclophosphamide. See, when we talk about sarcoidosis, we do not know the cause. It's actually a non-granulomatous response to an unknown antigen. It's somewhat idiopathic. We do not know the cause. Obviously, there is some genetic susceptibility in these particular patients, but still we do not know the cause. And the treatment is steroids, and you have to give some sort of treatment is basically you have to give some sort of corticosteroids, and you have to give some sort of immunosuppressants in this patient. Okay, next let's move towards our next question. So we are talking about activity. We are basically touching some sort of nuclear medicine in the case of sarcoidosis. The seventh question is, which of the following sign is seen on the gallium scan? Okay, so first thing you need to know that this is a gallium scan. You can see that there is some activity in the region of the eyes. There is some activity over here in the region of your parotid glands. And another thing, the favorite, the chest X-ray, you can see again there are bilateral hilar lymphadenopathy. Another thing over here is that there is also some right paratracheal lymphadenopathy. Okay, so there are 5 things which you need to remember when we discuss about the sign. And you can see that this is somewhat resembling like that of a panda. If you can imagine, if you can have a good imagination, this is somewhat looking like a panda. Okay, these black dots here and again in the chest region. So this is basically your panda sign. Okay, what about hot nose sign? Where is it seen? So hot nose sign is also seen in the case of brain death. Okay, it is seen on the brain death. What happens is that because the internal carotid artery there is no blood supply, there is increase in the blood supply in the external carotid artery, and because external carotid arteries are going to supply the blood to the nose becomes very hot in the case of brain death. So that is hot nose sign, whereas bullseye sign I would say is more characteristically seen with some sort of metastasis, either cerebral or liver metastasis, and it is very characteristically seen on ultrasound or CT. It's not a gallium sign. And boot shaped heart, you know that it's off, it's nothing to do with gallium, so you can rule this option easily out. So answer over here is panda sign. So if you see this particular image, this we have already discussed, panda sign. Okay, this we have already discussed. They can also give you a variant of this, a lambda sign. Okay, where there is no uptake in the head and neck region, but there is only an uptake in the mediastinum, which is lambda sign, which is basically bilateral hilar lymph nodes. Okay, and there is right paratracheal lymphadenopathy. Whereas if I talk about your panda sign, here there is an uptake in bilateral lacrimal glands over here, and there is an uptake in the bilateral parotids also. Okay, so that is basically two additional things in the panda sign. Okay, so now we have basically discussed about all these signs in the cases of gallium. Okay, again very commonly tested in some or the another way, lambda and the panda sign. Okay, moving towards our next question. A 40-year-old male has bilateral parotid swelling, uveitis and facial nerve palsy. Chest imaging shows hilar lymphadenopathy. Likely diagnosis is, again they have given you a hint of hilar lymphadenopathy in this case, so my mind automatically goes to either sarcoidosis or either tuberculosis. But when they are basically giving you bilateral parotid, again bilateral parotid we have seen previously in the gallium and sarcoidosis, we have seen eye involvement, which is uveitis, but that was basically lacrimal gland involvement in gallium. This is uveitis and facial nerve palsy. This is very characteristic triad of a disease which is called as the Hereford syndrome. Okay, which is called as the Hereford syndrome. So if you see over here this particular triad, you can see that there is uveitis, there is parotid enlargement, and there is facial palsy. This is something which you have to remember. Okay, Hereford-Waldenstrom syndrome, which is characteristically a variant of sarcoidosis, and again it is very commonly tested. Okay, so let's see why these so let's see why the other options are not there. So if I talk about Sjogren syndrome, they will basically give you the history of dry eyes, they will give you the history of dry mouth. Okay, not like facial nerve palsy or uveitis. Whereas parotid abscess is usually unilateral and it will be presenting with pain and fever. Whereas lymphoma, again there will be little bit more chronic history. They will either give you that there was past history of Sjogren syndrome, or there is a unilateral massive enlargement, some lymphadenopathy. So that is basically lymphoma. It will not present with this. So again you can rule out the other options as well. Okay, let's move towards the systemic. So let's now discuss about some of the systemic manifestations of sarcoidosis. So head and neck we have already covered. We know that there will be some sort of bilateral uveitis. Okay, we have already seen the Hereford syndrome. Okay, so uveitis hota hai, which is basically anterior. Another thing in the eye is basically optic neuritis bhi ho sakta hai. So optic nerves, if you see the imaging ke liye we need to go for a MRI. What is the best sequence to see these nerves? It will be a T2 weighted image. Okay, so if you see the nerves, they will be also swollen. Okay, they will be increased in the size. There will be some sort of T2 hyper intensity. Whenever there is some sort of inflammation, T2 will always increase. So there will be some optic neuritis. Okay, so they can basically show you an MRI image, a T2 axial image, and they can show that these nerves basically they will be enlarged and they will be having some sort of T2 hyperintensity. So that is one thing which can occur in sarcoidosis. Another thing, we have already seen that bilateral parotids can be involved. Bilateral parotids can be involved. So if there is bilateral parotid involvement, there is uveitis. Think of Hereford syndrome. Okay, another thing we have already discussed that there will be also uptake can be seen in the lacrimal glands, which we had seen. So lacrimal gland may be involvement ho sakta hai, which we have seen in your which sign? We have seen it in your panda sign. ओके, सो बेसिकली ग्लैंडुलर अपटेक हो रहा है, आईज में यूवीआइटिस और ऑप्टिक न्यूराइटिस हो रहा है, सो दैट इज बेसिकली योर हेड एंड नेक इन्वॉल्वमेंट. ओके, सो दिस इज मोस्ट कॉमनली टेस्टेड. इसके अलावा दे विल नॉट टेस्ट यू फॉर सार्कोइडोसिस. न्यूरो में व्हाट यू नीड टू नो इज दैट इन द ब्रेन, अगेन व्हेन इट्स वेरी वेरी रेयर दैट इट विल रीच टू द ब्रेन, बट इट कैन प्रेजेंट. इट्स बेसिकली sarcoidosis is a masquerader disease. When everything has been ruled out, we basically start thinking of sarcoidosis. So what happens is that there is pachymeningeal involvement. Okay, pachymeningeal involvement. So what happens is that your dura and the arachnoid, they are going to basically show what? They are going to be thickened. So you will see thickened meninges. They will also show good contrast enhancement. So that is basically a pachymeningeal involvement. Another thing is that it can even involve your pituitary gland. Okay, so pituitary gland में भी granulomas बन सकते हैं and the pituitary gland can be enlarged. So if you see this particular image, okay, it's little blur, but if you see that this is basically the meninges which are basically thickened. So this was basically a case of neurosarcoidosis in which there was pachymeningeal involvement. See, even sarcoidosis के बारे में हम बात करें and neuro involvement, they can even present as like a meningioma. मतलब it will look like a meningioma, but actually when you do the biopsy, it was a case of sarcoidosis. We have seen such a case. So what happens is that it can also present with large dural based extraaxial masses. ऐसे masses की तरह भी ये basically present कर सकता है. But this is not going to be tested on your NEET exam. So that is why I have not included such cases. These are like rare and atypical cases. But what they can basically test you is that there is some sort of pachymeningeal involvement. और meningitis के meningitis, there is some sort of pachymeningeal involvement which can basically be tested, and that is why I have included this particular slide. Okay, now one question which is there, it's little, I would say a little big question, but this is basically a USMLE style question. It's a clinical vignette also for the NEET PG students to get an hang of the clinical basically the how clinical scenarios can be basically put up in your exams, because many of the questions are now being given as a clinical vignette. So this is a little big. With this question also I am going to cover the cutaneous manifestations of sarcoidosis. So let's start with the question. A 38-year-old African American woman. See, we have seen that this is epidemiology भी cover हो गई. We know that it's more common in females. It is also seen in the African Americans. Presenting to the dermatology clinic with multiple skin lesions on her face and legs. She first noticed the lesions 3 months ago and they have gradually increased in number. The facial lesions are small. So we are talking about the facial lesions which are basically seen. She first noticed the lesions 3 months ago and they have gradually increased in number. The facial lesions are small, raised, firm, non-tender, papules, some coalescing into plaques around the nasal folds. Okay, so basically they are talking about the lesions. They can also give you just an image. Okay, this is I'm being very kind. I have just basically included the how it is basically presenting, but they will only give you an image in USMLE type of a question, and sometimes even in NEET PG they can test. So here there are some papules around the nasal fold region, and these are basically non-tender. But on the shin, she has tender erythematous nodules without ulceration. She also reports fatigue and 5-pound weight loss over the last 2 months. So another thing which they have shown is that on the shin, which we have already discussed, okay, this is erythema nodosum, because these are basically on the shin, they are tender. No other differential, it's erythema nodosum. She denies cough, chest pain or shortness of breath, no recent travel or sick contacts, no history of TB or autoimmune disease. A tuberculin skin test is negative. So we have basically ruled out tuberculosis. Laboratory workup reveals normal CBC and renal function, slightly elevated serum calcium. So again hypercalcemia, elevated serum ACE level. So itna to we have now, and a chest X-ray showing hilar lymphadenopathy. With all these things we know that we are talking about sarcoidosis. Okay, so so if you know that this is a case of sarcoidosis, okay, so they can basically you can basically reach to the answer, which is sarcoidosis with lupus pernio and erythema nodosum. Okay, so they will not basically give you sarcoidosis, they will give lupus pernio and they will give erythema nodosum, either of the one. This is for the sake of the lecture. I have included everything in this question, but they will either give you lupus pernio or either they will give erythema nodosum to you. Okay, so this is basically an image of lupus pernio. You can see that this female patient presenting with this pruritic non-tender papules. Okay, these are basically seen in the nose region, perinasal region, around the cheeks region, in this particular area. So that is basically your lupus pernio. Again, very characteristic of sarcoidosis. And this is erythema nodosum. These are tender nodules which are present on the shin. Okay, these are basically, if we talk about the pathology, it is a paniculitis. Okay, non-granulomatous, again paniculitis, that is basically present in the shin region. What are the other options given? This is a case of discoid lupus erythematosus. No, they will basically give you a very characteristic history of SLE in that patients, or ANA levels will be elevated or something like that. Whereas cutaneous tuberculosis, no, we have already ruled out tuberculosis. The tuberculin skin test is negative. And necrobiosis lipidica, it is something which is seen very characteristically in the diabetic patient. Okay, so this is basically, I have also included the explanation over here that these are yellowish brown plaques which are basically seen on the shins, usually in diabetics. So this is not a case of necrobiosis lipidica. Again, they look very aggressive. I will basically cover it in my future videos, but this was a characteristic case of lupus pernio and erythema nodosum. Okay, so cutaneous we have now covered. It is lupus pernio and it is, what is it? Erythema nodosum. Okay, so only last 2 points to cover. Okay, so let's talk about what is the last question. A patient with known sarcoidosis develop new onset 3rd degree heart block. What is the most probable cause? Okay, so whether it is amyloidosis, whether it is sarcoid granuloma involving the AV node, whether hypercalcemia, or whether it is pericardial effusion. Okay, so the patient has got a 3rd degree heart block. If the patient has got a heart block in sarcoidosis, whether you need to know, so many students will get confused whether it is B or C. So whether increase in the calcium level has something to do with the heart block or something like that. But no, it's absolutely pathological. It's absolutely the pathology, that is those granulomas getting deposited in the AV node, which are basically leading to this heart block. So sarcoidosis patients, they may have manifestations of heart block. They may have arrhythmias. All this occur because these non-caseating granulomas deposit in the conduction system or in the atria or in the ventricles, so that will lead to this particular symptoms. Another thing is that they have very characteristic site predilection for the deposition, which is in the ventricles along the septum. Okay, so this is again a little high yield question, I would say a high edge question, and I don't think so that it will be tested on NEET PG. It will be too much, but if you want to know, this is basically along the septum, and this is basically going to give you T2 hyperintensity and delayed gadolinium enhancement in the mid septal region. If you see this particular image, you can see that this is the right ventricle, this is the left ventricle, and this is the septum. So if you see that this is your septum in between the right ventricle and the left ventricle, you can see that there is some hyperintensity. This is a T2 weighted image, and you can see that there is some hyperintensity over here. This is because a sarcoid granuloma is deposited over here. Again, you can see that this is basically the distribution pattern over here. Okay, so the most important differential over here is that some sort of ischemia has occurred, and usme bhi basically they will have this T2 hyperintensities and delayed gadolinium enhancement, but they will have a vascular distribution. Okay, so I'm not going into much detail. This just need to remember that basal septum mein, ya fir even it can involve the ventricle, it is mainly in the mid wall, or either it is subepicardial. Okay, but never subendocardial. अंदर की साइड यहाँ पे subendocardial involvement जब होता है, that is mainly ischemia की वजह से होता है. So that is basically a differential. So this is little higher edge. This is only for radiologists who are basically seeing this video. It is either it is basically mid septal wall में होगा, या फिर it will be seen along the left ventricular wall, which is either mid wall में, or either it is subepicardial but not subendocardial. Subendocardial distribution जो होगा, that is mainly seen with whenever there is an ischemic insult and there is some sort of vascular distribution also. Okay, so that you need to know that it can also basically present with the ventricles can also be involved. Okay, there can be some sort of. So that was a little higher edge, but just need to remember that even your ventricles can be involved in this. Now if the ventricles are involved, they will either present with some sort of cardiomyopathy, or there can be some arrhythmias that can occur, and the main site of deposition is either in the septum or in the ventricular wall. But remember that it is always and always it is either in the mid part of the septum. It's not sub, जो ventricle की side होगा that is subendocardial, जो बाहर की side है that is basically subepicardial. So either mid में होगा या epicardial involvement में होगा whenever the ventricles are involved. Okay, again these are like very rare cases, but they have been reported. And lastly, MSK is something which I feel is very important. So if you see this, I have not included in MCQ because 10 MCQs were done. So now here you need to see that they will either give you hands or feet ka, they will give you an X-ray, and they will show you this very bubbly type of an appearance. You can see some small cysts over here. Okay, if you see this also, some bubbly appearance and some cysts are there. Okay, so this is basically your cyst-like pattern, or it is also called as reticular pattern. Okay, or either it is called as lacy pattern. Okay, these are all the keywords which are used in the case of sarcoidosis when the bones are involved. And remember that mainly predilection जो होगा वो hands and feet में होगा, and this is in the metadiaphyseal region. It's not epiphyseal, it is metadiaphyseal region. So hands and feet में you will have this metadiaphyseal involvement, and the bones, these are very well defined some cystic lesions, and you will see that there is an overall expansion of that particular bone. That bone which is there will be increase in the size, and there is some sort of your metadiaphyseal involvement with the or reticular pattern of sarcoidosis. Okay, muscles में भी involvement हो सकता है. When muscles are involved, granulomas can get deposited. अगर active होगा तो T2 hyper intense होगा. अगर chronically those granulomas have converted now into nodules, they will become T2 hypo intense. Again, it's a little higher age. And another important thing you need to know that arthralgias can be present, especially if it's an acute form. Like for an example, the Lofgren syndrome which we have talked about, the triad which we have talked in Lofgren syndrome, in which there was erythema nodosum, there was bilateral hilar lymphadenopathy, there was fever, and there was this periarticular uptake, especially around the ankle region, can be also seen in the wrist. Usually it is bilateral. Again, arthralgias can be present in sarcoidosis, and this is a characteristic case of and that is a classical example of Lofgren syndrome. But if I am talking about bones, this is the characteristic X-ray which they can show you. Another important thing on the bones is that it can also they can also show you acro-osteolysis. ओके उसमें क्या होगा, व्हाट हैपेंस इज दे विल शो यू अ डिस्टल फैलिंग्स. ये जो डिस्टल फैलिंग्स रहेगी ना, यहाँ पे तो कंप्लीट है, बट समटाइम्स व्हाट हैपेंस इज दैट दे कैन आइदर शो यू दैट इट इज रिसॉर्प्ड, ऐसे हो जाएंगी. दिस विल बी आधा द डिस्टल मोस्ट पार्ट विच इज देयर, इट इज रिसॉर्प्ड. यू विल नॉट सी इट इज आइदर एब्सेंट. ओके, तो ये जो है द डिस्टल फैलिंग्स विच इज देयर, इट विल बी रिसॉर्प्ड इन द केसेस ऑफ acro-osteolysis, which is characteristically seen with scleroderma also, or Raynaud's phenomena, but it is also been reported in sarcoidosis. Okay, so acro-osteolysis भी हो सकता है apart from your cystic or reticular or lacy sarcoidosis. Okay, so that was all about sarcoidosis in 10 MCQs. I have covered almost each and every aspect of sarcoidosis which is commonly tested. I have also given you some high yield and high age points which I feel that can be tested in any of the examinations you are appearing, and by this video I feel that you are going to crack sarcoidosis, and I'm sure you will be able to solve some of the most important questions of sarcoidosis. Thank you for watching. Do subscribe me if you want more such videos, and also please write down in the comments what other topics should I cover. Thank you so much. This is Dr. Natisha Arora.